Okay. This is, I got it, holy crap, this has been something I've been waiting to talk about at the roundtable for a while, so I'm really excited about the last talk. Is Rima watching this? Because I'm going to apologize ahead of time if Rima Rudd's watching this. You're going to hate everything that I'm talking about. But she's off the roundtable, so gloves are off.
Okay, you're done.
Okay. Yes, I know. Whoa, we're sweating up here. So a lot of the work that I'm going to be talking about is really, again, I think I was given the idea that I should be talking about what do you do about this. And after the last, Dr. Stefan, your talk was fantastic. I really appreciate this. It's a perfect setup, I think, for a lot of what we've been trying to factor into. A lot of the issues are really focused around now how health literacy fits into this issue of around cognition and what can you do about it. And what are some of the strategies, I think, is where I'm ultimately trying to get into. I do think it's important that just to kind of set the stage of what I'm going to be discussing, that there are a few assumptions that I'm putting into play with regards to, where I'm moving forward. So the first thing is that a person's cognitive skills are clearly a major determinant of health literacy skills, and that's something that, again, I joke about Rima, even though I think she has been great in this field and she fully recognizes it. I think she's more concerned about how we don't use that as a means to harm the field in some ways, given some other research on intelligence. But it really has been shown in multiple studies. Our team has been focused quite heavily on this for over a decade, and other groups too from University of Illinois and even across the pond in the United Kingdom have really factored that, yes, when you think about everything you need to do to engage in healthcare and how we envision and define health literacy, it absolutely relies heavily on cognition. But as we all have kind of recognized, and even if you look at that green, yellow, and red diagram that our colleague Ruth Parker has set the stage as an emblem for the roundtable, it does recognize that health literacy skills, though, what we need to manage health, the cognitive skill set that we have is very much determined on the demands placed on by the healthcare system. So how we set up the design, the accessibility of the healthcare system is really it's the test determines what you need to know. So again, nothing should be surprising, hopefully, at that point. When I think of cognitive burden and reducing cognitive burden, which is, I think, what my talk was supposed to be geared towards, I think of course, better communication. And we've heard throughout today that, we're not going to be losing jobs anytime soon in terms of finding targets within the healthcare system where we could do a better job of improving spoken or written or multimedia communication. There's still a lot of road left to do better. But we also need to be able to simplify patient roles. And that requires changing workflows and processes within the healthcare system. And I'm going to talk a little bit about that. And also having I love the term that came from ARC, and I see Cindy taking a photo here, learning healthcare systems. I think that is a new driving piece that is absolutely, okay, got it. The term there is phenomenal. How do you really start to kind of understand more about your patients by doing a better job of managing the data and acting on it, knowing who your audience is. And finally, addressing cognitive burden alone, I think we have to recognize very clearly will not remediate all existing health literacy concerns. So a lot of what we're doing, I think there's a new approach that we need to be thinking about, including revisiting what we call universal precautions. So there's two conceptual frameworks that I kind of merge and as Michael Pasciorlo likes to refer to it as the POW model on the right, which, well, I call it because you call it that, but yeah, there we go. Self-serving, but I think what's really neat, and it kind of caught my eye, and I know Steve also appreciates this up in Minnesota, Victor Montori's group, the cumulative complexity model, this focus that I think we're all coming at. It's like we're all talking about the same thing, just using different language to get at this notion of treatment burden and what the capacity of a patient is and how that kind of matches to the workload placed on them by being a patient and all the necessary roles that they have to assume that are determined by the healthcare system as well as their conditions. I think this really sets the stage for us really thinking about what is cognitive burden, where is it coming from? And to somewhat put this in the context of mental and behavioral health, I pulled from our data set. So we have it's a decade this year we recruited our first set of patients. So we've been following a cohort of patients called LitCog for over 900 patients for a decade. We'll have data of over 14 years in the current mechanism that we're recruiting for. And we've been following things, many aspects of an individual's cognitive performance, as Dr. Steffen had highlighted, and we've shown the strong correlations, as you can see, between cognition and many of the most common measures of health literacy. These are very, very strong correlations. So we do know that cognition and measures of health literacy are strongly correlated. We also know that one's ability to perform health literacy tasks are strongly dependent on one's depression and anxiety and their mental health. So increased depressive symptoms, increased anxiety symptoms, both in correlate affect one's recalling spoken instructions, accessing and using both print information, recalling multimedia information, and also basically what you remember from a 15-minute fast encounter, getting a diagnosis, some basic pathophysiology, and some treatment recommendations from your clinician. And we've published extensively on that part too. It also gets at healthcare problem solving and dosing out medication. All of these tasks ultimately are affected quite heavily by your mental health. And so we appreciate that. And we had previously also published that we also know that health literacy is also strongly associated not only with physical health, but with depression and anxiety symptoms as well. So I just kind of use that as a setting of the stage. Now getting back to cognitive burden, or what many people refer to as cognitive load, that really gets at the intrinsic and extraneous factors of what creates burden, or what's burdensome in terms of how one can perform a range of healthcare tasks. And I think I want to specifically focus on the cognitive load that is intrinsic with self-care task demands that increasingly patients have to navigate, as well as what we often talk quite a bit about, and there's many, many experts in the room here on health information instruction. And the goal really is to figure out what is the evidence and what can we be doing to minimize or reduce the cognitive load of both of these things. So first, deconstructing cognitive load of self-care tasks, and I'm going to be trying to rush through a lot of things, so I'm not going to get into any detail here, but going back to the Shippey model, or the cumulative complexity model, and thinking of disease burden and treatment burden, thinking about how hard it is to manage everything you need to do in a daily routine based on your current physical health, mental health, cognitive health. All of those things obviously determine your ability to focus, be attentive, and to make it through the day, doing all of the things that you may have to take, which include, navigating your healthcare providers, which may be many, your polypharmacy issues, your regimen complexity, along with polypharmacy. It's not just how many medicines you're taking, but are you doing medications that are dose dependent on biometrics, or that require different things like using injections versus liquids versus pills? All of that kind of falls into that bucket. Navigating medical devices or other involved technologies that are increasingly being kind of rolled out to patients, and thinking that they'll benefit them when in fact, if they don't have the technology literacy to go along with it, it may actually providing more cognitive load. And actually our colleague Denise Park has actually studied this quite extensively. Monitoring responsibilities and health insurance. I threw health insurance in there because I think that in itself could be another slide or two. Cognitive load of health information. Again, we know quite a bit what determines cognitive load. And I put up a couple articles from Denise Park, and I had a doctoral student who was faculty with us for a few years, Elizabeth Wilson, who did a lot of work on working memory and design of health materials, and also looking at how people process information, whether it be procedural or factual, and how is it done versus audio visual versus audio alone versus in print form. How do people optimally comprehend information, and how that actually definitely what can alleviate cognitive load and what also creates more distraction. Everything from the most obvious, reading grade level, to information that's discordant, that shouldn't be a surprise. Some interesting things that also really create a lot of unnecessary cognitive load on documents, I thought, was some words on inappropriate imagery, having images that don't provide nothing to add to the content, but just are these nice pictures of people doing healthy things. But if you're describing the pathophysiology of your high blood pressure and, not that doesn't make any sense. It actually creates distraction and comprehension failure. Steve's done some great work on communication speed. Another thing on all these things that may or may not be targets, but a great deal can be done to reduce the cognitive load that we've been able to show in just how we relay health information. But there are three takeaway messages, getting to really, what you already may know and what I'm hoping to kind of talk about today that are important. I think one, to recognize that health literacy disparities in patient health outcomes should be treated as an outcome that looks as how we look at whether or not there's evidence of a healthcare system's excess cognitive burden on patients. So if we see disparities by literacy in patients, lower literate patients are not achieving the same outcomes or the same benefit of treatment in a particular chronic disease or have worse physical or mental health or getting more hospitalized, I think it shows that there's more work to be done in trying to make sure that a healthcare system recognizes that you have a diverse patient population and you need to be meeting the needs of everyone. My target on universal precautions, which I've always had a bit of an issue with in terms of how that gets rolled out, is that I don't think, and especially with what we've been talking about just recently in the past presentation, and also where there's greater attention to things like mild cognitive impairment, we have to recognize that it is not okay to just assume that you can do one thing and just assume that if you do good communication through all, that if you do not have a good mechanism of maybe finding the most vulnerable patients who may not be coming forth, who may feel stigmatized not by a mental or behavioral health issue, but by the fact that they don't feel that they're comprehending information very well, and the healthcare system may not be as inviting. Finding ways to identify people who still may be missed by universal precautions, I think, is important. And I think a number one health literacy goal really is about reducing the cognitive burden of health information. I think there's other things in too that we can consider in the health literacy bucket that would get at processes, but I think more importantly, the overall healthcare system goal really is about reducing treatment burden. And that is stuff that falls outside of what I would say is typically health literacy. It's getting a healthcare system to think more about how it's providing care to patients. And so it's a much bigger issue around quality improvement that I think health literacy has to tie into. The Captain Obvious slide is, again, takeaway message number one. This should be pretty obvious. Breaking news, patients are not the same. Individual differences exist. We have to meet patients knowing that they all have diverse issues. And we know this because the people differ in terms of whether it's cognitive abilities and education and cultural and language and age and comorbidities. All these things affect your health literacy. And there's other things too, but this is a simplified model from a chapter we wrote on health literacy from the Handbook of Behavioral Medicine. And, I think by the very fact that we know this, we can't have that one-size-fits-all kind of solution. We really have to recognize that there is a group that, yes, everybody may benefit from good health information, but some people may still be missed if we don't know who they are. So my second takeaway message really is, again, this issue around universal precautions. And really what we've learned, and there's significant evidence on this in multiple studies, that we can reduce the cognitive load of print health information, for example. We can make material by following all these principles dating back to Doak and Root to the many, many iterations that have been since in terms of just optimal design of health materials. But you are not going to remediate those with the lowest literacy skills. And I remember at I think it was a heart conference several years ago at the National Academies. I made the dumb comment, but it was a very obvious comment to say that it's taken me over 20 years to figure out that if someone doesn't read very well, why am I still giving them print material? There's just a problem where we recognize that we can only remediate so far. But we have been able to show those who are on the fence, we can do better by just optimizing what we know better. But there's still a group that's going to be missed. And evidence for interventions optimizing multiple multimedia and spoken health information and practices is currently limited. It's actually, again, even as recently in 2017, our group from UC San Francisco and others have shown considerable health literacy disparities across use of patient portals to other web-based tools to mobile apps. I mean, there's an issue that we have not yet really optimized, even though I would kind of highlight to ARC and to Cindy Brock's, driven focus on the patient education materials assessment tools, that there are ways that we are learning on how you can optimize or at least rate the suitability of multimedia information. And fresh 2018 systematic review out of Montreal, you know, there's a positive component to it, but there's also a little bit of a somewhat pessimistic view of how well we can actually address self-management among lower health literate patient populations. By doing a review of, there's many issues I would probably challenge about this article, but this came out just recently, and it does show that basically multifaceted, probably problem-solve-based interventions that are quite intensive for self-management are most successful at reducing that disparity, that literacy disparity. But again, it's challenging. It's much like what we saw dating back years ago to like Russell Rothman's work and others that show that yes, a kitchen sink intervention that is highly intensive and maybe not that replicable can in fact make some gains, but yet it's going to take a lot of work. So moving beyond universal precautions, so just again, don't want to say that I'm against it. I think, yes, we constantly need to get healthcare systems to be doing more, to just focusing on everything they should be doing. Where there's a strong evidence base, they could be doing materials better. My guess is that even though there is so much knowledge known about how to do things better on communicating in print, in spoken counseling, et cetera, that most people are still failing to take action, and that's just a big issue we need to work on. But I do think beyond universal precautions that we have to recognize that reducing cognitive burden, doing these things better in terms of health information, there's going to be 1 in 5 adults that are not going to be captured, that are going to be missed. And that could be because they are, I use the term cognitively compromised, because it's not that I'm saying that they're all impaired. I'm saying like everything we've been talking about, whether it be due to illness, due to just being the fatigue of a heavy regimen requirements because you've got multimorbidity. There are lots of reasons why you may really have a challenge and you're not like what we've just heard. You can understand but not really comprehend. And helping those patients may require something different. How we remediate someone actually could be quite different. So a pitch that I would suggest, and who knows, maybe Hark will accept this. We've submitted this with our team, is that going back to the LitCog sample, we just realized from a recent attached project to this study, we funding from the National Institute for Neurological Disorders and Stroke, we went back to our sample, and whether through diagnostic codes or through performance-based identified through our neuropsychological battery, that there are about 201 patients who actually have a mild cognitive impairment or dementia. The majority of them are undetected in primary care. Yet most manuals of health literacy would say you need to rule that out a little bit, but most people would say only those with severe. But if you look at across the most common measures of health literacy, you look at what happens when you remove the sample of patients who actually have a mild cognitive impairment. Look specifically in the low health literacy. Obviously, when you remove them, rates of low health literacy go down significantly across all 3 measures and jump pretty high among those with what we would consider have a mild cognitive impairment or greater. And the reason why that's important to me is because I think the way you remediate someone who may be in what with the classification might be cognitively normal versus those who are impaired would be quite different. And also what I would say is that the fact that we have such significant delays in identifying patients with MCI, there's a lot of reasons for that, but it's also what our neuropsych team who's involved from the Alzheimer's Center on this grant get frustrated with, because they know that there's things that they can do with someone if it's detected earlier, versus making the assumption that maybe better patient education or something else might be able to remediate it. So just as a thought. Again, so maybe there are different health literacy phenotypes, and maybe the reason you have low health literacy could inform your solution. Takeaway message number 3, health literacy, the number 1 goal, again, reducing cognitive burden of information, but we need to move beyond it. So I really think a lot of our focus has to be on just getting everybody, whether it be involving the Joint Commission to say, we know a lot already, why can't we just have some follow through to make sure healthcare systems are doing their best to impart universal precautions, optimizing their health materials, thinking about how they can engage with patients beyond the point of care and making sure that they're engaged in their care. I think there's lots of things that we know, we just need to have them implemented. But I think beyond health literacy, the reducing treatment burden side, if someone, especially who has significant cognitive impairment, and that is affecting their health literacy and self-management skills, we have to think of other things. And there's a lot of activities going on here. So can we consider identifying vulnerable patients? And should we consider some screen or some way with big data to consider that we need to know if you are low health literate, because it may not be so obvious, and we may also, the nature of it may determine how we can best respond to help you. Can that identification translate to maybe if I knew I would spend more time with you, that the visits in primary care could not be 15 minutes sandwiched between two healthy 30-year-olds, someone who's 72 with 4 chronic conditions, taking 9 medications, and who is actually not achieving goal on the majority of them. Or even more frequent visits. Can you consider deprescribing initiatives, helping to reduce that burden by maybe not all medicines are needed at this point. That's a very challenging issue, I think, right now. Involvement of caregivers, of course. How do you ensure that they're sharing the patient portal with patients, that they're kind of requisite that they come to appointments? How do you involve them? And also assess their health literacy as well, making sure that they actually have the competencies, thinking about trainings to that regard. And I know I'm wrapping up here, but home healthcare services, consumer healthcare technologies, better health information exchange, this gets out to the learning healthcare systems. All of these things could be possible solutions that we might want to consider, again, if we only knew more. And I think this is a significant issue for us because, it's this confluence of two issues here, that as we get older, we naturally develop multimorbidity. We have more and more issues that kind of fall into our plate, greater self-management demands. And at the same time, that is happening when we already see kind of a natural age-related decline, let alone higher rates. As many as 16 to 25% of patients in primary care, the estimates range, have a mild cognitive impairment, and a lot of that goes undetected. So I'm going to leave it here. Thank you.